Ohio River Valley fever, a classic case of disseminated histoplasmosis in an immunocompromised patient. Histoplasmosis is an opportunistic infection caused by the dimorphic fungus Histoplasma capsulatum. This fungus is endemic to the U.S. states bordering the Ohio and Mississippi rivers and other parts of the world, including southern and East Africa, as well as parts of South and Southeast Asia. Commonly associated with soil rich in organic matter like guano or bird droppings, the infection is asymptomatic in most individuals who have been exposed to it. When symptomatic, it is primarily a pulmonary infection. However, it can present as a disseminated syndrome involving multiple organ systems like the GI, CNS, adrenal glands, and skin, especially in immunocompromised individuals. Untreated, disseminated histoplasmosis is rapidly fatal with a mortality rate of up to 90%. A 30-year-old male presented to the ER with a 2-week history of high-grade fever, chills, dry cough, dyspnea, and watery diarrhea. He revealed he had been diagnosed with HIV at a free clinic 7 months prior. He had been established with a PCP who prescribed HAART but never took it and never followed up. When he developed these symptoms, he made an appointment with his PCP who sent him to the ER immediately. On presentation, he was febrile with a temperature of 38.8 Celsius, tachycardic with a heart rate of 114 beats per minute, and hypotensive to the 80s over 50s. He was also hypoxic, requiring supplemental oxygen. The patient reported a history of immigration from Mexico to the U.S. as a child. He had also been briefly incarcerated a few years ago. He had never been tested for TB. Interestingly, he was currently employed cleaning grain silos and cargo trains in a yard in rural northeastern Illinois. On further questioning, he confirmed there had been some construction work in the area recently, as well as recent rainy weather and humidity. Within the first hour, the patient received a sepsis bundle, including IV fluid boluses and empiric antibiotics, which improved his blood pressure. Labs were significant for mild anemia, relative neutrophilia, and mildly elevated bilirubin. His CD4 count on admission was 124 cells per microliter. The CT of his abdomen showed mild retroperitoneal lymphadenopathy. The patient was placed in isolation and started on IV Zosyn and IV vancomycin empirically to treat for sepsis. Given his history, a differential of miliary TB as well as disseminated fungal disease was considered, and relevant testing was ordered. His quantiferon test was eventually negative, as was the first ASV sputum culture. Histoplasma and blastomyces urine antigen tests were both positive, but the histoplasma antigen titer above the limit of quantification. Due to the endemicity of blastomycosis in the same geographical region, it was still on the differential, and co-infection was also considered. For definitive diagnosis, bronchoscopy for BAL staining and direct visualization was recommended, but the patient declined the procedure. Meanwhile, the patient's diarrhea, which was originally assumed to be a manifestation of GI involvement of fungal disease, was diagnosed to be Campylobacter jejuni diarrhea, for which he was started on azithromycin and eventually improved. Testing for other opportunistic infections, including pneumocystis pneumonia, cryptococcosis, coccidiomycosis, and paracoccidiomycosis, as well as aspergillosis, was negative. The patient was started on treatment for disseminated histoplasmosis with liposomal amphotericin B. Over the next few days, he rapidly improved with return to room air and resolution of his cough. The patient's renal function began to decline because of the amphotericin B, so he was switched to PO itraconazole after day 5. The patient left the hospital against medical advice, despite being